Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. Today's episode features Dr. Karim Fizazi from Gustave Roussy in Villejuif, France, and Dr. Alicia Morgans from Northwestern University in Chicago, Illinois. They will be discussing the use of androgen receptor-targeted agents in the management of non-metastatic castration-resistant prostate cancer, including updated safety and patient preference data presented at the recent ASCO 2021 meeting. This episode is part of a larger educational program titled Current Topics in Oncology, a focus on prostate cancer. For more information on Dr. Fizazi and Dr. Morgans, along with a link to the complete program, including a downloadable slide set covering the content of this podcast, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
Hello, I'm Karim Fizazi. I'm a medical oncologist from Institut Gustave Roussy in Villejuif, France, and I'm delighted to be at this podcast today about non-metastatic castration-resistant prostate cancer. I'm very lucky because I'm sharing this with Dr. Alicia Morgans. Alicia?
Thank you so much, Karim. It is a delight to be here. My name is Alicia Morgans, as you've heard, and I'm a GU medical oncologist at Northwestern University in Chicago. So pleased to be able to give really an international perspective between the two of us, I hope, on non-metastatic CRPC.
Absolutely. So, I guess we all know that the current treatment for those men with metastatic castration-resistant prostate cancer has dramatically evolved in the last 3 years or so, thanks to large randomized trials. Alicia, can you just summarize the main data of these trials, please?
Absolutely. And as you've said, it really has been an era of change, particularly in the non-metastatic CRPC setting, where just a few years ago, we had new options that not only could help prolong the time for patients to develop metastatic disease in this setting, but also we found could prolong survival. So the Spartan trial, Prosper trial, and ARAMIS trials all assessed patients who had no evidence of metastatic disease on conventional bone scans and CT scans, but did have rising PSA during treatment with androgen deprivation therapy. Importantly, patients in these trials also had a PSA doubling time that was calculated to be 10 months or less, which is really, I think, critical as we think about this patient population, because although they are asymptomatic for the most part, those patients with short PSA doubling times are at highest risk of developing metastatic disease or dying from prostate cancer. These patients were enrolled and were randomized to treatment in Spartan with ADT plus apalutamide versus ADT alone, in Prosper with ADT plus enzalutamide versus ADT alone, and in ARAMIS to ADT plus darolutamide versus ADT alone. And they were all followed for a primary endpoint in all three trials of metastasis-free survival. So that's the time to develop metastatic disease or death from prostate cancer. This was found to be longer in each of the trials with the combination of ADT plus apalutamide, enzalutamide, or darolutamide versus ADT alone, and led to the approval of all three of these agents in the non-metastatic CRPC setting. Critically importantly, we did find about a year and a half later that in addition, that earlier intensification of treatment also led to improvements in overall survival across the board with all three agents, really demonstrating to us that earlier intensification strategy is something that we might not be able to make up for. If we add the treatment later, we might miss that window of opportunity to have that significantly improved overall survival. So critical advances, and of course, you were really part of this. And I think it was exciting and important for us to see some updated safety data from the ARAMIS trial that you actually presented just this year at ASCO 2021. Can you share a little bit about that?
Sure, of course. So basically what we did was try to assess safety data in the long term. So basically after patients had crossed over from placebo to darolutamide for those who were on placebo. And even with much longer follow-up now, it appears that darolutamide really has a highly favorable safety profile with basically minimal differences observed versus placebo during the first part of the trial. And even in the long term, we don't see much more toxicity appearing. So this was, I guess, the first main message from Olorasco presentation. The second one was that the discontinuation rate was extremely low. Actually, less than 15% of men on darolutamide had to stop drug at a given time, and actually 9 out of 10 of these men could restart with darolutamide. And of course, as you said, we have clear demonstration now that overall survival is improved. What we did in this analysis is try to correlate the magnitude of the PSA decline with overall survival, and it appears that indeed there is quite strong association between maximum PSA declines from baseline and longer overall survival, which may actually be something important to consider for future clinical trial design. So this is what we had at ASCO this year. But I would like to ask you a different question, Alicia, if you don't mind. These agents are slightly different, at least chemically they are different. So can you explain what are the mechanisms of action and how actually the chemistry can make a difference?
Absolutely. Well, as we know, all three of these agents are androgen receptor antagonists. So they really act at the level of the androgen receptor to prevent testosterone from binding and activating that receptor. But importantly, there are some distinct structural differences that I think should be mentioned because they can lead to differences as we see clinically and certainly as we've come to see in some of the studies that have been ongoing. Enzalutamide and apalutamide are actually relatively similar, and if you look at them side by side, they're really nearly identical, save a ring or so. But what we can see with darolutamide is that it does have a structural difference that really does set it apart. Certainly, its active component that binds the androgen receptor does so effectively, but the structure of the molecule is so different that it actually changes the way this agent can penetrate the blood-brain barrier. And this, I think, could lead to some differences in side effects because enzalutamide and apalutamide, we know, can penetrate the blood-brain barrier. We have seen very low, but apparent episodes of seizure activity with enzalutamide in particular. But again, it's still very rare, but it does suggest this blood-brain barrier penetration. And we've also seen levels in animal studies that are measured to be different between enzalutamide, apalutamide, and darolutamide. And darolutamide, again, just really doesn't seem to penetrate nearly as well. So I think those structural differences do make a difference and can affect things like toxicity. Now, considering that and considering all that you know about these agents, because you've used all of them, how do you actually choose between these agents when you do have a patient with non-metastatic CRPC?
Right. So actually, it's a good thing in oncology, generally speaking, when you can choose. It means that you do have a choice, which is great in the setting. And well, generally, my philosophy is, of course, first based on availability, and I know that all these three agents are not necessarily available, or at least all three in all countries. So that's of course super obvious. You take what you have, of course. But besides this, my first goal as an oncologist is obviously efficacy. And this also applies in this setting because men with non-metastatic CRPC and a rapidly rising PSA, so PSA doubling time of less than 10 months, actually don't have a very good prognosis. So, increasing the efficacy remains key for these men. And it's great to see the metastasis-free survival and overall survival data with the three agents. Having said that, I think that it's fair to say that the efficacy data are very similar. So this is not necessarily a parameter that will help me for decision making between the three agents if available. So then it goes to toxicity and quality of life. And here I think these three agents are not made equal. For example, enzalutamide, which we're using for a long time in the clinic, has some side effects. Obviously not in all patients, but a minority of them report significant fatigue or cognitive impairments. And an old man who might have difficulties in concentrating might fall down and break his leg. And actually there was an excess in falls and fracture in the trial as compared to placebo for enzalutamide. That also applies to apalutamide, which also has some other side effects such as skin rash, of course not major, and also hypothyroidism. On the other hand, darolutamide was very, very similar in terms of side effects as compared to its placebo. Probably the only real side effect that we could detect was a slight increase in fatigue incidence, 12% versus 9%. And actually this is much higher with enzalutamide or apalutamide. All the rest is really, really similar. So that would be a very important reason for me to prefer darolutamide over the two other drugs. And finally, the last point is obviously cost. If ever one drug is really much cheaper as compared to the two others, that could be perhaps also something to consider in the decision making, also depending on who pays, of course. Well, the systems are not necessarily equal. So, Alicia, based on all this, efficacy, toxicity, so how do you console your patients about those side effects with AR targeting agents?
It's a great question, and I wish that there was a better answer, because a lot of the side effects that we see in the setting of these AR targeted agents are actually driven, I think, predominantly by the androgen deprivation therapy backbone that's underlying all of them. These are things like hot flashes and fatigue that can happen simply because you have just such low levels of testosterone and low levels of testosterone signaling because of the additional AR antagonist. Usually I do encourage patients to try to exercise and be as active as possible, which can help with the fatigue and also with some of the side effects of muscle wasting or muscle atrophy rather, that can happen just because of the low testosterone and of course the fatigue, which can tend to make people less active. And of course things like hot flashes or the sleep disturbances that can come from that, as well as from just having low testosterone, are things that are more difficult to deal with. So just simple things like having access to a fan, avoiding things like caffeine that can sometimes make people warm can be helpful. But a lot of work actually, I think, needs to go into the field in this particular aspect of care so that we can make these side effects a little bit more manageable. We definitely need more supportive care. And fatigue, I think, is one of the most challenging ones. And of course, one of the most multifactorial, or one of the side effects that is caused by multiple angles. And I wonder, I know you've looked into this a little bit. Have you seen any differences in fatigue in particular between the different agents? I think you presented some information on this from a patient preference study, the ODENZA trial, earlier this year.
Correct. Yes, indeed. So the design of the ODENZA trial is really randomizing men with castration-resistant disease to receive either darolutamide first, followed after 3 months by enzalutamide, or the reverse sequence, enza first, daro second. And obviously, the main goal was to try to assess whether there was a preference between the agent. And actually, there was a mild preference, not marked. Approximately 50% of men preferred darolutamide, 40% preferred enzalutamide, and 10% didn't really have a preference. But besides the preference question, the trial design allowed us to assess direct toxicity comparison at 3 months, because before this time, patients had seen only one drug. So I guess we can compare it. And we indeed saw some slight differences, and actually this is reflected also by the patient's preference. And actually the first reason why patients prefer darolutamide was less fatigue, as you pointed it out already. So I think this is an important thing to remember. The story is not over, because we also ask patients during the course of a trial. We ask them to fill cognitive questionnaires. We are currently analyzing them, so hopefully we can report the data later on this year. And I think this will be a very nice way to objectively assess whether those two agents have different cognitive toxicities or consequences in all the patients. So stay tuned. Hopefully, again, in some weeks or months, we should have the data. But Alicia, before we finish this conversation, can you tell us more generally, how do you manage patients with asymptomatic non-metastatic CRPC? How do you image them? How often do you see them? How often do you measure PSA? What is your practice?
It's a great question, especially because I think that there isn't a clear standardized method for this. But generally, I have these patients, of course, already on ADT, which means for the most part, I'm seeing these patients every 3 months to continue to give them their injections. That's the duration of injection that we most commonly use in our practice. And I do see that when we first start treatment, I typically will add our AR antagonist and then have patients come back within a month so that I can check labs, make sure that everything's okay in terms of their side effect profile, and ensure that they feel comfortable and that they have a plan moving forward that makes sense for them. It also gives us an early look at PSA, although I guess it's not always the case. We usually will see some PSA decline even at that first 1 month check. Then I will typically have patients come back if there are any concerns or complications, sort of more frequently if they're on apalutamide for another month or so. But for darolutamide and for enzalutamide, we typically could have them come back 2 months later if all is going well, if labs look good. And I would encourage people, of course, to do what they feel comfortable with and what's on the package inserts for these medications. But that's typically how I do it. And then as long as everything is going well, we typically will have them return every 3 months. That being said, if the patients develop any symptoms, or certainly if there's a rising PSA, we will intervene at the time that those occur and get imaging. Now, imaging is an area of rapid flux in this disease, and so sometimes that imaging is going to be standard conventional imaging, but actually increasingly we're using things like PET scans too. So that's a whole nother thing to think about, and something that we probably don't have the bandwidth to discuss on this call or this podcast, but is something that I think is interrupting the field and may shift at least how we think about things, if not necessarily cause us to change our backbone of treatment. Because to emphasize, I think, in the 3 trials that led to the approval of non-metastatic CRPC treatments, enzalutamide, darolutamide, and apalutamide, patients actually continued on therapy until conventional imaging, radiographic development of metastatic disease. So patients can stay on even when there is a PET scan that is positive. Finally, I would just say that I do, for patients who are on apalutamide, for example, keep tabs on whether they're developing a rash. We keep track of their thyroid, typically with TSHs and reflex free T3 and free T4 every 12 weeks, just to make sure, again, that we intervene where necessary and follow up on those complications if they occur. What about you?
Well, it's very, very similar. I guess regarding the imaging, I would base my decision also depending on how good does the PSA. In men with very low PSA values, I would probably image routinely just once a year in these men. Now, in men with a response which is not so good, I would probably image more often. But otherwise, it's, I think, very similar. I think also it's fair to say that we now have great reason to intensify these patients with an AR antagonist, next generation AR antagonist. And this is a new thing. We were not doing this until basically 2018 or so. With both metastasis-free survival benefit and overall survival benefit on top of it, coming together with multiple benefits, PSA, pain, etc. So any final thought, Alicia?
Yes, I guess my final thought would just be that I think it's really critically important for us to identify these patients, again, by conventional imaging. Even if a PET scan is positive, if the conventional imaging is negative, and that's bone scan and CT scan, and PSA is rising despite ADT, and that PSA doubling time is 10 months or less, that patient meets criteria for intensified treatment with one of these agents in addition to ADT. And I think that early initiation after identification is critically important, because we've seen with that overall survival advantage that if we add the drug later, even as was done in the control arm of all 3 trials, we can't seem to make up for that added benefit that we get by that earlier addition of therapy. So really, identification and early intensification would be my final thought.
Absolutely. So with that, I thank you very much. It was really a pleasure discussing this data with you today. Thank you, Alicia.
Thank you so much, Karim.
Thank you very much, Dr. Fizazi and Dr. Morgans, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, current topics in oncology, a focus on prostate cancer, and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.